Many private practice physicians are in big trouble. We have not received a payment increase from Medicare for decades. Now, when you take into account inflation, of course. As a matter of fact, payments have continually decreased when you account for inflation. How can you afford to continue to operate in an extraordinary inflationary economy now with impending recession and worse yet, stagflation? When this question was raised in the private practice physician Facebook group, I read an interesting and passionate response from Dr. Virginia Thornley, a solo private practice neurologist in Sarasota, Florida. She suggested numerous ideas to increase collections. In case you missed her post response, we will talk about some of these ideas in this brief video. And as always, if you are watching this live or on the replay, please share your questions and suggestions in the comments. As she wrote in her response post, time is gold. I really appreciate Dr. Thornley today for sharing her time with us. Welcome to the program.
Hi, John. Thanks for having me. I'm always excited to share what I know because I'm a huge advocate for private practice for physicians. I think it's the way to go because, we're the ones who are most well trained and we need to take control of what we do.
I 100% agree. And I think before we came on live, you said a critical word, and that is control. I think so many of us feel burned out because we lose control. And what you have done is to rein in some of the control by starting your private practice. And those of us in private practice, and so it's interesting, you are in solo neurology with an N as in Nancy, and I'm in solo urology with a U, uniform. So a little bit of background, you were in a hospital, working in a hospital, and then you started your private practice, I think, during the height of the pandemic. Mm-hmm. And then in 2 years, you are moving into your own building in about 2 weeks. So super appreciative of you taking time away during this absolutely hectic period of your life.
Yes. Well, let me just backtrack. So I've been in practice for about 10 years. I was always employed. And I was originally with a private practice. I used to work in New York City. And so I was able to gather a lot of information that I incorporate into my private practice, things that I want to have happen and things that I don't think would be necessary. And then I moved down to Florida because of the nicer weather, realized I wanted to be autonomous, and then broke away, did my own solo practice, and I actually moved into my new 11-room building, which we purchased March of this year, all part-time. So this is all doable, part-time, in the middle of a pandemic with no loans or line of credit. And if I'm a subspecialist and I depend on refers and I had no loan, if I could do it, any doctor can.
So that's a great message. What you said in particular really intrigued me in your response. I mean, you wrote a very lengthy response to one of the questions in the private practice physician Facebook group. You wrote, figure out how to bill literally every breath you take, such as phone calls, non-face-to-face work, records review, and talking to doctors. So first of all, tell us about a little bit of how you set up your practice and also what you mean by what you just wrote.
Well, ever since the beginning, I always knew that I never wanted to overspend. My overhead is so low. When I first started out, I was the only person. It was me, myself, and I. When I got busy, I hired an assistant, and she's only part-time. We're both part-time. And yet here I am. I own my own practice. I own my own office, 11 rooms. So the first thing I knew I had to master was how to give value to every single minute that I have. And as a neurologist, I spend a lot of time on my patients. So I learned within a year through many informational sources like the Facebook groups, et cetera, other doctors, that if you bill for time, you can maximize that. So that would be a 99205 for 60 minutes. And then a follow-up would be 215 for 40 minutes as a neurologist, I easily spend that time. I don't have to worry about all these other requirements. And then on top of that, if you write your own notes, if you review the records ahead of time and you tally all of that up, you coordinate care with your assistant, that's another 15 minutes. That's $20. If you have 5 patients, that's 100 in a day. Times that by 5 days, that's 500. That's already 2,000 extra for a month. So I'm already doing the full 205 and 215. And then on top of that, you can screen patients. And I'm not saying go out of your way to do this. I incorporate this naturally in my practice. If somebody's telling me they've got anxiety, depression, then I will do a depression screening. That would be G0444 in Medicare. That would be a 96127 for for commercial, and that would be an extra 17.96. So even doing this alone, that's another $17.96 per patient. You add that up, that's another 100 per day. That's 200 a week. So if you follow what I'm saying, every single thing you do, you can bill. And you don't have to see 20 to 25 patients every day just to earn. I'm just taking care of my patients, and what I do, I give value. If patients call me, which I prefer not to, because I prefer to see patients in the office. But if, let's say, there's something critical and I can't have them come in and I have to counsel them, if it results into documentation and it has to do with counseling or advice or anything that I have to do on my end, then I will bill for that. I have the patient look at fill out the financial terms of agreement. That way they know ahead of time. So 5 minutes is a 99441, so that's about 46 with Medicare. 10 minutes, let's see, that's 5 to 10. 11 to 20 minutes, that's a 99442. That's 76. By the time they reach 21 to 30 minutes, that should have been an appointment. So I try not to talk to patients on the phone because A, you're spending all this time giving your counsel, your expertise, and you're not giving value to your work, which you work so hard for. So if it's a complicated patient, I just have my assistant say, okay, schedule an appointment. If it's something that I have to address, side effect, they're feeling sick, then I will tell them, I need to document this because this is documentation. Anything, if our conversation lasts more than 5 minutes, I will have to charge you. And either they get off the phone quickly because, my time is gold. I can't afford to spend 30 minutes on phone calls. They understand that I have other patients too. So the patient understands all this ahead of time so it doesn't ruin the relationship. Now, the other activities that I code for include things that we already do anyway. So if I have complex patients, which I have a lot of, sometimes I may have to reach out to physicians that same day. Sometimes other days I get histories and medical records. Now, if I reach out to a physician and it's part of the same day, if it lasts more than 15 minutes and I'm coordinating care, then I will document. Spoke to Dr. So-and-so from 10:15 to 10:30, 10:31. Again, every extra 15 minutes is a G2212, that's for Medicare, and then it's a 99417 for commercial insurance. So that's an extra $20 every time you spend 15 minutes of physician-related activity. Now, as a physician, I often get patients who are coming out of the hospital. Sometimes I'm a second opinion. Sometimes they come from another state because I live in Florida. So I get a lot of snowbirds. I get a lot of patients who come out of the hospital having strokes, needing follow-up. I will sometimes they will bring records. Sometimes I will request records. And, I'm lucky if it's only the test results that I need, but sometimes I get 120 pages, which is a lot. And you have to go through every single word because there might be something that is crucial, and I can't really shortcut that. So I will bill that. I will look over the records, every single page, and then I will document. 30 greater than 30-minute non-face-to-face work, that's 99358. And I will document, I reviewed and summarized 121 pages, and then I will summarize and type all the things that are necessary, but I do document the work that I do. And then I will code for that. So that's a 99358. The problem is with Medicare, you can document that and bill that the same day. Some other commercial insurances, such as Blue Cross Blue Shield, they will not pay for the same day. You have to do it on a separate day. I did that with Aetna, and they did not pay the same day. I tried it another day. I'm waiting to hear back. So some commercial insurances, they may not pay for that. So you have to also figure out which insurances will cover which codes. And if it doesn't work, you can always do a G2212 the same day. That way you're still billing all the work that you do. A G2212 would be for Medicare, but for commercial, it would be a 99417. And then you would document the time. It'll probably be less because it's $20 for 15 minutes. So as you can see, every breath I take, I put value. And I'm very strong with my boundaries. And, people don't want to hear it, but if you're going to go into solo practice, you really can't afford to give away your services for free. So I always outline all this in my financial terms. And if patients don't like it, they walk away, which some do. But other patients, they will read that because it's right before the signature. And so as soon as they got on the phone, because I answer my own phone calls after between 1 and 5. If it's administrative, no big deal. But once it's counseling, they immediately get off the phone. They say, okay, I'll call tomorrow. And that way they don't use up my time. But again, if it has to result into a document, it involves counseling and advice. Anytime it's more than 5 minutes, I will document, I will let the patient know, and then I will bill for that.
I don't even know where to begin. That is so amazing. So there's so much in that. What you just said, there's so much to unpack there. It's incredible. So I'm gonna try to address. I jot down some notes. Mm-hmm. You fully understand coding. There's no doubt in my mind. Not many people understand the nuances of a 99358 or a G2212 or 99417. Or the 2021 E&M rules, how you can bill based on time, and that time is no longer involving 50% requiring coordination, counseling and coordination of care. That's gone as of 2021. You fully understood that. And you also set up policies so that when you see the patient, before you even see the patient, they understand your principles, your core values, and if they want to play in the game under your guidance, in your rules, they can. And thankfully, there are other physicians who may not have strong boundaries like you do. And I don't think it just matters to solo practice physicians. I think every physician should know their worth. And for so long, we've had the luxury, or maybe we just didn't know any better. We've been giving away our services for free. And I think look at plumbers. Before they even do anything for that service call, they already charge you. Look at lawyers. Every time you pick up the phone and talk to them, they are charging you based on time. What is different about physicians? Right? It shouldn't be.
Yeah.
So when you are talking about billing based on time, for some specialties that works really, really well. In urology, I will tell you about 50% of our work RVUs come from evaluation and management. And as you already know, evaluation and management can be billed based on medical decision-making or on time. You are utilizing time. In urology, my position is that urologists are most efficient or more efficient when they are billing using medical decision-making and not based on time. Again, it varies depending on specialty, but in urology, you are much more efficient and much more productive billing based on medical decision-making and not based on time. Again, it varies by specialty, but the bottom line is every physician needs to understand the 2021 E&M coding rules if you are a participating provider using a third-party payment scheme. insurance companies. What do you think?
Absolutely. Yes. So depending on your specialty, you really need to understand how to code. In neurology, because I tend to serve a much older patient population, and most patients, they almost always come in with more than 4 neurological disorders. It's not uncommon somebody will come in with migraine, cervical pain, lumbar pain, cognitive impairment, gait impairment. So it's difficult for me to just spend a short amount of time, because my specialty tends to lend well with spending time with patients. So I take advantage of that in the sense that I will bill every minute, because the coding allows me to do that. And if somebody has anxiety, I may add some counseling. That's another thing you can code for, 90833. It's another $77 or 15 minutes of counseling, but that takes away from the appointment time. So for me, I'm able to see 5 patients a day and still pay my overhead, acquire a building, because I'm in neurology, I'm purely clinical. And with my population, I tend to, just by the nature of my specialty, I really need to spend time with my patients. It's very difficult to work up a new patient from scratch, trying to cover 7 neurological disorders, because I tend to go over everything, and almost everybody has at least 2 or more neurological disorders. Do the full neurological exam, do the MOCA, the Montreal Cognitive Assessment, and then come up with a plan. So that's how I developed my practice, and I found that with private practice, it actually works well for neurologists, because we can spend the time that we want, but you just have to understand how to code and how to bill for every minute that you take.
So that's the dilemma, right? You can do that. However, physicians are being gaslighted into thinking whatever the CMS payment is, that is your worth. So some of us have thought, well, how do you maximize that? Seeing patients and charging based on time kind of limits you.
Mm-hmm.
But on the other hand, if you bill based on medical decision making, you may be, well, enticed or be simply doing kind of like running a hamster wheel. You just keep running faster and faster and seeing more and more patients in order to maximize productivity. Mm-hmm. So you kind of have to look at it from both sides. Mm-hmm. Also, those of us who understand evaluation and management in 2021, you can have a single problem that is worse that you're managing, evaluating, assessing, and treating, and you prescribe medication, or after you talk about the treatment options, you end up prescribing a medication. That's already a 99214 or 99204. That's already a level 4 visit, just by dealing with one problem that is worsening for which you prescribe medication. And that covers most primary cares. Mm-hmm. Single problem that is worsening, exacerbating, and prescription drug management. So understanding the problem, understanding the risk, and you only need 2 elements in medical decision-making to reach a level in 2021. So one problem, worsening, and risk, boom, you're already there at 99204. Again, we are being gaslighted into thinking that is all we're worth at 99204 and 99214. So always keep that in mind.
Yeah, that's a good point. And yes, it is important for physicians, especially busy ones, on learning the new terms of encounters, that the medical decision making, you may need less time for a patient, and you can actually bill higher is if you understand what the terms for coding would be. So I think it works both ways. You can do it based on time, which lends well for my specialty, but busy private practice primary care doctors, if you're seeing a large number of patients and you're making these medical decisions that are complex, you really have to understand your coding. That way you can maximize it. So I'm glad you're bringing that up, because a lot of doctors, they have to understand how to code.
Well, if it's just like, it's no different than in my previous presentations, I always say that this is no different than taxes. You're just playing by the rules that are given to us. you're not doing anything illegal. You're just playing by the rules. But the problem is, most physicians are great clinicians, but we don't take the time to understand the rules and being able to apply the rules. That's also a separate thing. So my question is, you clearly have a pretty in-depth understanding of coding and billing. How did you get there? That is always the question, the how.
It's funny. I think I just kept learning about it. Information is free on the internet. You do not have to hire consultants, which are $7,000. All the information that I got when I built my practice was from clinical experience and reaching out to colleagues that I knew in person, old classmates, the internet, private practice doctors, and all you have to do is Google it. It sounds crazy, but I always, as a neurologist, I always wonder why things are. So it comes second nature to me. So I Googled threads for coding. How do I code? And I had an idea before, and then I implemented it. So I would look up codes, and I would take note of threads with coding. I would apply it to my practice. I would see what sticks. If it sticks, and I kept doing it. And then if it didn't work, I would ask my biller, okay, why does this code not work? What is the correct CPT code and ICD code that will match? And they would say, okay, you have to use this one. So I wouldn't go out of my way to do it. But if it applies to my patients, that's what I would do. The other thing that I do that I don't think many physicians do is that I go over every single EOB, so electronic online billing. So when I get a batch of mail, it's nice to have a biller, but you have to pay attention to all your billing. And I think that's where the problem lies. When you look at the EOB, you will understand billing in much more depth. So when I look at an EOB, I will see, okay, patient responsibility, that's what the patient pays. Insurance paid $0. So I say, okay, why did insurance pay $0? So I connect with my biller. Why did this happen? And they would say, okay, there's no referral, no prior authorization. You used the wrong code. So, and then I keep learning and building on this. So one thing that I learned was I need to make sure that I check insurances even before I see the patient. A lot of doctors don't do that, and then they just wait for the billing to come in. That's where you lose thousands of dollars. So number one, you have to understand the coding, the billing, the correct CPT with ICD. If you let it go, you're letting go of your value and your worth. I mean, unfortunately, that is how insurances work, but you have to understand it. So every week I get a batch of mail, and then I will see, okay, this didn't pay for this. And so I figure out, okay, why didn't insurance cover this patient, but it didn't cover that? So I asked my biller. And apparently sometimes 99417 is used for some patients because they have certain plans. G2212 will work for other patients, and they're still Aetna. So they have different plans, but those certain plans have even more specific plans. And then I look at another one. Okay, why did the G2212 not work? And I think it was because I had to be 99417. So anytime I don't get paid for a code, I go back to my biller and say, okay, why did this not work? And he said, okay, it probably has to be a 99417, not G2212. And then the other thing is that sometimes I tried billing I think it was for counseling, and I thought it was preventative counseling, but apparently it was for obesity. So I used the wrong code with the wrong CPT. So that's how I learn. When you try different things and then you put the claim through, if it doesn't work, you always have to question things why things are such as they are. And the other thing is that I'm active in a lot of Facebook groups. So whenever there's a thread going on coding, I would take note, I would write that down. And again, information on the internet is free. You just have to look for it. If you don't look for it, you're not going to find it. I tell that to my patients too when I work them up. So I'm always very curious about things. So I looked up all the threads before I went in. Okay, how to code for this. So I wrote all the threads with coding. I applied it to my practice. I looked through my EOBs and I thought, oh, this actually works. And I was pleasantly surprised that 90833 actually works, because I do a lot of psychotherapy, meditation, counseling on my anxious patients, and that pays $77. So you're already putting the work in, but you have to figure out how to bill for every breath you take. And the problem is, oh, I'm busy. I don't want to do that. I don't want to document. Well, you're losing all that income on the table. And it's not about being greedy or wanting to make money off your patients, but we are physicians at the end of the day, but we're also business people. If you are a private practice doctor, you need to pay for your overhead. You need to pay for your staff. You need to pay for your bills. And if you're not getting paid for that, you're going to get stressed out. When you're stressed out, you're not a good doctor. It shows in your demeanor. You get more patients, you're more stressed out, and it's a vicious circle. So I came to the conclusion that I'm better off seeing less patients, but I can spend time and I could figure out how do I put value in every breath that I take. And that's what I do. I would just look up codes and see if I could code for something. And I've just built up all these codes that I list. I said, oh, I could use this. And so instead of seeing 23 patients like I used to when I was employed, and I was spending 10 minutes on new patients, which is very difficult in neurology, I can spend that 60 minutes of time because that's my comfort level. So you have to have a comfort level where you feel complete, but you're doing a good job and you have value in what you're doing. So it's all interrelated.
Yeah, again, so much to unpack there. And when I say this, it says something is disconnected, but we'll see. When you say it, in my presentations in the past, I've said this. Your patient's success depends on your success. And another way to say it is that, what a lot of business people say is that no margin, no mission. If you are not profitable as a practice, you will not have the privilege to take care of patients. A lot of physicians forget that. And often we are so busy running on the hamster wheel that we keep working in the business and you don't take a step back and work on the business or work on your coding and billing and understanding the importance of documentation, understanding why a particular EOB comes through a particular way, this explanation of benefits. Why does it come across this way? Why are you not being paid for a particular service line? And if you don't care about that, or if you don't want to deal with that, make sure you hire someone who is competent. And you implied something in what you just discussed, that communication between you and the coder and biller. You are constantly going through this iterative process of learning, claims being denied, claims being paid, and you're learning about what works and what doesn't work. So that is something that a lot of people don't pay attention to. And in summary, it's really the entire revenue cycle. You have to understand the entire revenue cycle and not just putting your head down and doing that clinical work. If you want to be, I don't know, in my opinion, if you want to be really happy and knowing what's going on, and I think so much of physician burnout is lack of control, not knowing what's going on. Part of that is not knowing what's going on with your coding and billing, not knowing anything about revenue cycle, not wanting to take time to learn about documentation. And if you want to work in this third-party payment system, unfortunately, you have to play by the rules that are being laid out.
Yes, correct. And I don't know, I think I just have a knack for it. And, billing, I must say it's very boring, but it's so necessary in building your practice, because if you don't understand your billing, you could be losing so much income. And I hear all these stories, oh, I've got 10,000 in collections, I've got 30,000 in collections. I'm thinking, you need to pay attention, doctor. And so I learned from every single mistake. So the first couple of mistakes that I made was if someone has a deductible. It's very difficult once a patient leaves your office to go after that. Now you're sending letters. Now you're sending 3 letters. And I've never sent anyone to collections because I don't know that I feel comfortable. But I learned that if someone has a deductible, to collect that up front and then you issue a refund. It's a lot of administrative burden, but it's so much easier. And now maybe I'll have to go after 2 or 3 per month rather than 30 in January when I first started out. So every lesson I learned from mistakes. So number one, when I first started out, I started July 2020. In January, there was all these deductibles. I didn't understand it, and patients would get mad once you told them we have to collect. So now, ahead of time, whenever someone schedules an appointment, we check insurance and we say, "Listen, Mr. A, you have a deductible for January. If you don't understand, please call your insurance company. If that's not something you agree with, maybe you need to clarify that, but we will collect a deductible. Otherwise, I may not be able to see you." And then once it clears, the submissions go through. If there's a refund, we will give that refund. So that's one. The other thing is our copays. You have to check copays, deductibles, insurances before the patient sees you, not after the fact. And I learned that if you wait until last minute, you don't get information, you submit the claim, and now they owe you $350, and you don't see the light of day, then you've lost so much income. So now every new patient, we tell them we take this, this, and this. Aetna, Blue Cross, Medicare. We check every insurance. Medicare, they tend to be much more straightforward. I don't have a lot of problems except during January. But every commercial insurance, it's very difficult because even when we submit claims, it even changes. But at least checking it up front will minimize that. And we tell the patient, "Dear Miss C, you have a deductible of $2,000. We want to let you know, and if you have a question, call your insurance company. We will be collecting at the time of visit." And this minimizes a lot of angst, a lot of bad feelings on the doctor and the patient. The patient's thinking, "Oh, my insurance should cover this. Why is this doctor collecting from me?" The doctor's feeling, "Oh, I gave this service. Why do I not have value?" And then you butt heads and it ruins the relationship. So I learned at a very early time that I don't want to butt heads with my patients. I don't want to ruin relationships because, trust me, once they lose trust with you, they will never see you again. It doesn't matter if you are correct. It's easier to explain things ahead of time than after the fact. So number one, deductibles in January, make sure you collect everything up front. Let them know you'll issue a refund. Number two, if you're seeing patients with commercial insurances, check the deductible, copay, prior authorization, and referral ahead of time. Referrals are usually HMO patients. Don't get it after the fact because now you've lost income. Number three, if they have a copay, and this is something I learned the hard way, do not wait till the end of the visit. Collect all your copays up front because if their credit card gets declined, and you keep asking for collections, you may not see that collection. So these are very hard lessons that I've learned. And again, it's not about, it's not about increasing income. It's trying to deliver good care. You don't want to ruin your relationship. And when you earn, you can improve your practice. And I went from a one room, tiny little office because I knew that I wanted to buy an office. I went from a one-room office to an 11-room office that we purchased after 1 year and 9 months of being solo. And that was because I paid attention to my EOBs. I paid attention to these hard lessons that I had to learn. They were painful, but I never made those mistakes again. And even though we would check up front, sometimes I noticed even when we submit claims, it would still be different. And, I just have to chalk it up to business, but we did the best we can. And now I'm not ruining as many relationships as I used to because now they understand what we plan to collect. And the ones who really value you, they will stay with you despite these problems with insurance. And at the end of the day, you want to help your patients, but you need to pay your bills to do that. And you have to have the adequate facilities because when I was in a one-room office, I was taking phone calls from the ER in the parking lot. So that was not going to work for me. So I knew that was time for me to move on. And now I've got more space. The patients are happy. "Oh, lovely office. I love it." I'm happy because I have room to grow. And it's a win-win situation for patients, myself, and the patient-doctor relationship. And when you grow, you can give better care to your patients.
Absolutely. Oh my gosh, so much so much to unpack in what you just said. Again, understanding the revenue cycle and knowing when that starts. That starts from the very first phone call that the patient makes to you. You have to collect. It sounds like what you're saying. You have to collect at the beginning of the visit, not at the end of the visit. And for experienced clinicians, based on the presenting problem, what that visit is probably going to be, a level 4 or level 5 visit. even before the visit begins. So determining that and estimating that and then collecting that upfront at the beginning of the visit, performing something called benefits verification and eligibility verification before the patient even arrives. And like you said, communicating that to the patient before he or she arrives in your practice so that there's no surprise. Guess what? For the Medicare patient, it's January 1st, your deductible reset. You need to know that is happening. You have not met any of that deductible. You are going to have to collect that from the patient for that January 2nd visit that the patient's coming in to see you. So benefits verification is super important. Eligibility verification, if that insurance is even working for that particular patient. Is the subscriber even eligible? So these are things that needs to be done before the patient even gets there. And then collecting the copay, coinsurance, and unmet deductible. That has to be done every single visit. For a lot of practices that I speak to, they will reschedule the patient if it's a non-emergent visit. They will reschedule the patient if they don't pay their unmet deductible or unmet balance that they have carried forward. I have given a lot of presentations to a lot of coders, billers, and office managers and physicians and APPs. When I ask this question at every meeting, no one has ever said, I would rather collect after the fact. And the question is, would you rather collect before at the time of the visit, or would you rather chase after the dollar? No one has ever raised their hand and said, I would rather collect after the fact. The value of your service as a physician goes way down once that service is rendered. It's just like anything else. To that starving man, that piece of bread that you have in your hand is priceless. Once that bread is consumed, right? Same thing. No different than any type of service or product that anyone offers. So it is important to collect up front. And I will tell you, for probably over 10 years now, the largest bucket in my practice, the largest bucket of revenue comes from patient responsibility. So people are thinking, oh, high deductible health plans, that's something relatively new. That's been going on for a long time. And if you have one of these Obamacare plans, I had one. The deductible for the family, aggregate deductible, was over 5 figures annually. So until the patient meets that deductible, you will not get anything from the insurance company. It is your responsibility as a practice to collect that up front. And if you don't do that, just think, largest bucket has been from patients for over a decade now, for me. If I just skip that, I don't think I'll be able to continue to practice. I don't think I'll be as happy. I don't think I'll have the time or the mental capacity to do things like this, what we're doing, to share this information with other people. So you being successful not just helps your patients, it helps your practice. And now what we're doing is helping other physicians. How do you like that?
I know sometimes it's mind-boggling. One other thing that I must point out is I do have self-pay patients, so self-pay or cash, because I only take 3 insurances because I'm part-time. That I always wanted to be part-time, and I see threads, I see people discussing this, and sometimes it's also you always have to pay attention to the front desk because you have to make sure they collect everything. Some of them may feel shy about it, but it's a business at the end of the day. What you collect from patients will pay their salary, and you can give cash bonuses, cash gifts, but if they don't collect it, that will not happen. So you have to be on top of that. I do see some threads where, oh, the front desk is not collecting, they're not checking these things. So it's not just about understanding it. You also have to be on top of things. Also, when it's also easier when you warn the patient ahead of time, which I also learned from experience because they don't want to be surprised by a bill. So that's how I came up with the terms of my financial terms. If I do this amount of work, then you will be charged if not covered by insurance. They are much more accepting if you warn them ahead of time rather than plop it on them after the visit. And then with self-pay, I tend not to collect up front. I do it after the visit because I don't know what services I give them, but I will give them a ballpark estimate. And you have to understand your value. When I checked into what was a good rate, I just called around, but you're supposed to not do, but it's always good to know. And then I would say, oh, what's the rate of this doctor? And I didn't want it to be too high where it's unaffordable. I'm not really like 40 years of practice, but I don't want it to be too low. So just right. And you have to give value to your self-pay rates, because if you price it too low, it means, oh, she doesn't know anything, she's not worth it. If you price it too high, you can also miss a whole category of patients who need your help. It has to be just right so that you place value on your expertise, and it's also affordable, but just right so that it's not too low and they think that your knowledge is not good enough. So it's a fine art, but you learn how to finesse it.
You bet. And there's nothing wrong with calling around for what other people charge. You just can't. It's such BS. Insurance companies know what each other charge, right? And so in the background, they can set prices and sort of a quasi collusion. Yet physicians cannot get together in a room and share our negotiated rates with insurance companies. But that's changing starting yesterday. So what hospitals are charging and what insurances are paying these entities, hospitals, and physician practices is going to be mandated that this information be released so that everyone can see it. So consumers, patients, potential patients can shop around for the best deal. So hopefully it's getting closer to that free market, not quite, but closer to that free market economy in healthcare, which is going to drive better value and decrease costs and increase efficiencies. So I can't wait for that to happen.
Yeah, sounds great. Yeah, it's always good to be transparent so everybody knows what's going on.
All right. Well, you know what? I have taken so much of your time.
Oh, I didn't realize it's an hour.
when based on what you wrote and what you have written in the private practice physicians Facebook group, I knew that you would be passionate. And this is the first time we've ever spoken. So I knew we would get this type of valuable information to our audience. And I hope somebody takes away from this interaction and be able to act on it so that he or she does not have to keep turning on the hamster wheel and be able to practice in a thriving medical practice. So
absolutely.
Yeah. And I want to congratulate you for less than 2 years actually buying and owning your own building. That is quite a feat. And certainly your knowledge of coding, billing, revenue cycle, and your interest in making sure that you run the best practice possible so that you can help your patients. I mean, that's truly exemplary. So congratulations.
Thank you. I appreciate it. And I actually own the office space of the building. It's not quite the building, but it's 11 rooms. It's still more than I ever expected, but it's great. And the reason why I spend so much time trying to enlighten other doctors, even in real life, is because I wish that every doctor could have the same satisfaction and gratification of owning their own practice, taking control of medicine, taking care of their patients as they see fit. Because when you are autonomous, you can practice the way you have been trained to do. And, I think we've all been brainwashed that you have to be employed, you have to follow administrators. And in the back of your mind, you understand that it doesn't make sense. Why are you following all these suits, all these administrators? They're telling you are not good enough, when in fact physicians should be leaders in medicine. And that's why I feel so passionate about it. And it really saddens me when I hear from patients when they tell me, my doctor only spent 5 minutes with me and couldn't even spend that much time. And I told them the reason why I'm spending so much time is because I own my practice and I have control over what I do. And my understanding of billing allows me to spend the time that I want with my patients. So I wish, my wholehearted wish for every doctor is, I wish they could feel the same gratification and satisfaction of owning their practice. I still haven't lost hope, which is why I spend so much time writing these threads, because I know somebody out there is struggling with their job. They want to get out of the rat race. They want to control and own their own business. And so I, who have already gone through all these hoops, all these humps, now it's my turn to give advice similar to other physicians who gave their advice to me. So I want to also reach out to other doctors and tell them it's going to be okay. You are one of the most well-trained professional on the planet to give medical advice. Never doubt that. The business part, you will learn. You will make mistakes. You will learn from that. Do not be afraid, because once you lose that control, now you're seeing all these things that are not working, that are not helping patients. You know in your mind it's not working, it's not the right thing to do, yet you feel helpless. But if you are on that path and you know you want to take control, private practice is not dead. And I'm living proof. And I'm doing this part-time, which is amazing, which sometimes I surprise myself. But once I started owning my own practice, I knew that this was what I was meant to be. And I wish doctors would feel that way again.
Wow, that's amazing. It's truly inspirational. Thank you so much, Dr. Thornley, for your time. There's just so much to share, so much to unpack. And I can hear the passion in your voice, and I totally agree with you. I am in the same boat. My job now is to pay it forward. I've stood on the shoulders of giants in the past, and that's how I'm able to get to where I am today. So that is not lost on me. Now it's my turn to pay it forward. Thank you so much for your time, Dr. Thornley.
Thank you so much for inviting me, and I hope my message gets spread, and I hope we continue to promote private practice for physicians.
Well, there you go, everybody. Private practice is not dead. And if you understand the rules of the game, you can play in this arena, not just survive, but thrive. Any questions or comments, as usual, please feel free to leave them. And we look forward to interacting with you soon. I thank you so much for the privilege of your time. Remember to take care of yourself and each other. Bye-bye.